My name is Matthew. Today I'm going to be discussing airway assessment and patient positioning. So the first thing I'm going to be discussing is the airway assessment. So the airway assessment is used for any general anaesthetic, any patients requiring invasive or non-invasive procedures, and any rapid sequence intubation. The aim of a good airway assessment is to identify any potential problems or abnormalities that you may come along when you're trying to oxygenate and ventilate a patient. It can give you a good indication if a patient may be difficult to ventilate, any potential problems you may come along with intubation, and if any contingency plans are needed to maintain the airway. So for the airway assessment, we use an acronym called LEMON. A mnemonic called LEMON. So the first step is the L. So we're just going to look. So it's just a general visualization of the patient's face and sort of body shape and all that sort of stuff. So one of the common things that we may have, like you see in males, is facial hair. So if someone has a beard or any facial hair, it can affect the seal of the mouth and make it quite difficult for them to ventilate. Other things, there might be signs of any trauma, bleeding, any tumours or abnormalities or defects. These are other things that might cause you a little bit of trouble sort of maintaining ventilation. Also, you look at the neck shape and size as well. Do they have a little short neck? If the patient's a little bit larger as well, a bit more obese, it can make the airway management a bit more difficult. The next letter that we're looking at is the E. So we're doing the to evaluate. So you're using the 3-3-2 technique. So this means you use 3 fingers doing between the incisors and the teeth, opening the mouth. So we measure there 3 fingers. The next step is the 3 fingers between the hyoid bone and the chin. So the hyoid bone is just located just above the epiglottis there. And the last one is the 2 fingers distance between the thyroid notch and the floor of the mouth there. So we just use 2 fingers there. Another thing that you could use is the thyromental distance. So to do that, we're going to need a pen torch, which will come in useful later on as well, as it's got the ruler there. And what we're doing is we're just measuring from the thyroid notch to the chin, the tip of the chin there, and it should equate to about 6.5 centimetres. Next letter we're moving on to is the M, which brings us to the Mallampati score. So we're going to have to use the pen torch now to have a look inside the mouth. If it's a bit dark to sort of see it. So the Mallampati has 4 classes. Class 1, you should be able to see soft palate, the uvula, the forceps, the pillars, all visible. Now in class 2, only the soft palate, the uvula, and the forceps are visible, so you shouldn't be able to see the pillars. And in class 3, it's just the soft palate and the base of the uvula that you can sort of see. And in the class 4, you can only see the hard palate. So obviously class 1 is a more favourable assessment, and the class 4 means it might be a difficult airway. The next one we're going to look at is O. So any obstructions. So anything that might cause a bit of an obstruction that you can sort of see in the airway. So any defects, any large sort of epiglottis or swelling, any angioedema, any trauma inside the mouth or any bleeding. The last one we're going to discuss is the neck mobility. Now, in a conscious patient, you might be able to get them to twist their heads to left and right and flex and extend it as well. They should be able to do this 90 degrees. In an unconscious patient, it may be a bit difficult, and if you consider any C-spine injuries, then you might not be able to test neck mobility. Further assessment tests that you might be able to consider as well is a temporomandibular joint mobility. If the patient's conscious, it just requires them to bite the upper lip with the bottom of the teeth. And you just want to identify the cricoid membrane as well, just in case there's any failed intubations and you have to resort to a front of neck airway. So you just have a check there. So next we're going to move on to positioning. So the first position we come across is the sniffing position. So this is just achieved by placing the towel under the base of the occiput there. So what we're trying to achieve here is have a 30 to 35 degrees angle of the lower cervical spine and the upper cervical spine, and just a 15 degrees forward displacement of the anterolateral occipital joint. Now with this position, you just got to be careful. If you suspect any C-spine injuries or anything like that, it should be avoided and use manual stabilisation. The next one is ramping. So this one puts you in a position to align all the auditory meatus and the sternal notch in a horizontal plane. So to do that, I'm just going to grab some blankets. So we're going to use this to place underneath the patient here. And I'm going to roll the towel and place it here so that when he comes in line, the audible meatus is in line with the sternal notch there. And what that does is align your pharyngeal axis, your laryngeal and your oral axis, and it assists in sort of intubation and airway management of the patient as well. Now, for things you would like to document down as well, so a good one to document down is the Mallampati classification, so class 1 to 4. Any findings in the airway assessments, felt difficulty. With the Lemon assessment as well, it's scored out of 10 and then minus 1 mark for any negative criteria that you may have come across during the assessment, and added to the Mallampati score as well. Any difficulty encountered while assessing the airway, position the airway to an adequate to the view of the glottis. Was the C-spine immobilized or required? It's good to have open communication with everyone on the scene about what you're going to do as well, to ensure all members know their roles and what's going to happen, especially when it comes later on into when you have to intubate the patient or perform any other further airway skills. So just things to consider as well. So avoid the sniffing position when the patient has suspected C-spine injury. The laryngoscopy can be performed using the manual inline stabilization of the head. So with all of these blankets, is having the manual inline stabilization with someone assisting you. Avoid neck mobility assessment again if there's any C-spine technique. And then if it will assess the patient upright as possible, will increase the functional residual capacity and decrease rate of breathing and oxygen consumption. Ramping position should be withheld unless the patient is slightly on the larger side, but it does align all the axes and puts you in a nicer position for intubation. All right.